Thank you, Sarah. Hello, everybody, and thank you for joining us today. In our wrap-up session, in our discussion, mute your phone if you're... in our wrap-up discussion on working with youth with, I'm going to say, multiply occurring needs. The learning community is dedicated to youth with co-occurring disorders, and we're going to talk about some change in language as we approach that today. At any time today that you have a comment to add, a question, some helpful input, some non-helpful input, if you want to talk about the restart of the baseball season, please enter anything into the chat box. Whichever one of us is not rambling on, and by that I mean mostly me, being the rambler. Rick will be the one monitoring the chat box while I'm rambling. So anything you put in, we will try to attend to and include. And certainly the benefit of a learning community is increased greatly by participation. So I think that's all I have to start with. Anything that you can think of, Rick?
No, Mike, I just want to welcome everyone to our final, over many years of doing this, learning community for youth with co-occurring disorders. And what you're going to find is a compilation of all the years of doing this. And I think many of these, if I'm not mistaken, and Sarah can correct me, and now it's my phone, are also recorded, many of these, and you can find them on the YouTube channel.
Yeah, and hopefully, hopefully they are there. I looked, some of them are, and I couldn't find all of them, but I'm not good at looking. So, Sarah, if we can go to the next slide, please. This is an interesting slide. We're going to go to the next one. All right, so and then here is the YouTube channel that Sarah was referring to. This is through the University of Maryland School of Social Work and related to the TA network, and links to the learning communities, and then we'll link to the YouTube channels, and not just on the topic of youth with co-occurring needs and disorders. But many youth-focused, family-focused, different learning communities. And so hopefully it will be continue to be a helpful resource. And as Rick mentioned, many of the previous discussions that we've had can be found and linked through here. Okay, next slide, please. All right, so as Rick mentioned, I'm going to get rid of my son's cat who has occupied my lap here. As Rick mentioned, we're going to go through, I have become what I have started to pick on, which is people sharing cats and pets on Zoom. I'm sorry. But we're going to go through the topics that we have covered over the course of, I think it's 6 years that we've been we've had the opportunity to talk about through the learning community about topics related to youth with really multiply occurring complex levels of interactive need. And as we started our discussions, and as we started talking about youth that we're talking about today, we retained the language of youth with co-occurring disorders. And that's going to have an evolution as we talk about the different topics that we covered. So I'm going to introduce just the titles of the topics that we covered, and then we're going to quickly go through each of those topics after that. So, and again, at any point, if any of these topics stand out, if you want a little bit more discussion, what did you talk about in that, please add that to the chat box, and we will try to, we'll try to expand on that. So. Our very first one, when we started talking through the TA network, was prevalence, expectation, screening, and assessment of youth with co-occurring mental health and substance use disorders. This was really aimed at increasing the recognition that if you are working with youth, if you are serving youth between, I don't want to say in between certain ages, but generally we think 12 and 18, 12 and 20. If you're serving those kids in that age range, a significant portion of the kids that you're working with will have co-occurring needs at some level. And so we were hopefully increasing some of the recognition of that and some of the ways to screen for, and then and maybe a little bit more deeply then assess for that. Next, we talked about evidence-based practices and promising practices as they are matched with different levels of care in serving youth and families with co-occurring needs. We did a topic on families and opioid use, and there's a reason it was families and not youth, families and opioid use, and we'll talk about that in just a minute. We did one dedicated to suicide prevention, recognition, and again, that was really, it was a prevalence and expectation, and then screening and matching treatment for suicide prevention related to youth with co-occurring needs. And then we kind of ended that first series talking about clinical workforce development, and that was one that I was, Rick and I were both, I won't speak for Rick much, that I was really excited about, because with all the rest of the stuff that we talk about in terms of increasing clinical recognition, increasing service availability, none of that means anything if we don't have a workforce that can deliver on what we're talking about. And I think everywhere across the United States, there is difficulty in finding clinicians right now, and especially clinicians that will voluntarily and willingly work with youth with really high levels of need, because there are so many areas of specialization in that. And so we spent quite a bit of time talking about some very specific areas of clinical workforce development. And that was one that I was really happy with. At that point, then, we moved on into what I'm kind of considering the second half of our conceptualizations and our presentations, because at that point, then, we did a presentation and a discussion about complex trauma as it overlaps with the other areas of need in talking about youth with co-occurring disorders. And it was really at this point then, I consider it a bit of an evolution. We didn't really change any of our conceptualizations of youth with co-occurring disorders in multiple areas of need. It changed our language just a little bit in the intentionality of our language and our focus. And so we're going to talk about that next. Sarah, the next slide, please. So in our discussion of complex trauma, we really started to pull trauma out as a separate point of consideration, and something that I had, I guess, been guilty of, or had been limited by limiting my conceptualization of before that, is that very often I included trauma in the mental health circle in this slide. And that really I had a two-circle focus of overlap with mental health and substance use. They both exist independently of each other and can be recognized independently of each other, and then there's a point of overlap, and that that intersecting points of overlap are what our intentional focus was. In working with youth and families for quite a while, in terms of direct clinical service, and then with several years of doing some TA work and some consultation work, working with programs across the country, and really hearing a whole lot more clinical perspectives, really began to understand how important it was to conceptualize, to consider not just individual trauma experiences, but the deep level complex trauma or developmental trauma that so many of the youth that we were working with and serving have experienced and lived with and have become a part of who they are right now as teenagers. And so at that point, we pulled trauma out as an entire separate area, that it can be identified individually by itself, separate from mental health and separate from substance use. And so really it's not a turning point necessarily because it was considered before, but it was an expansion in the same direction that we were going before. Anything to add to that, Rick? Because that was a big part of your conceptualization, and you kind of guided me in that direction.
You know, the only thing I would add, and this is a theme throughout, and is keeping in the forefront of your thinking that it's one youth, one assessment, one treatment plan. And so no matter how many bubbles we end up with, and however complex the conceptualization becomes, you know, our goal is always to be as youth and family friendly as we can be. And it's one kid, and we got to figure them out with one assessment and one treatment plan, so that we're not having 3 different providers, for example, having to intervene with this youth and the family have to tell their story multiple times.
Yeah, and that really has been the message of integration throughout, and that decreasing the contacts and thereby hopefully increasing engagement with the youth and families. The fewer times they have to tell that same story, and the more they can integrate a single approach with a single provider, the greater the chances that they are going to remain in treatment. And I think it was Bill Miller who said, you know, without engagement, you don't have anything. So if we can't keep them engaged, we can't provide any service. So thank you. Sarah, the next slide, please. So here is kind of where we expanded just a little bit in terms of the way that we were conceptualizing and presenting, in that our language about co-occurring disorders evolved into the language of multiply occurring needs. And so there's a couple of changes in there. More linguistic than anything, but hopefully they guide the evolution of the conceptualization. Co-occurring to multiply occurring, in that it's ironic that co-occurring doesn't imply enough complexity. Because we've been trying to get people to move to understanding and recognizing that youth with co-occurring needs are there. If there's mental health there, it pretty strongly predicts the likelihood of some substance use being there. And if there's substance use needs there, that really strongly predicts that there's mental health needs there. And that's complex enough. But the more we work with youth and families and programs that provide service to youth and families, the more we realize that it's not that simple. And again, that's an ironic thing to say, because there's nothing simple about that. But the level of complexity, as soon as you have needs on the mental health side and on the substance use side, the level of complexity just grows. And so we think a more telling term is multiply occurring. On the other side of things then, rather than saying disorders, we have moved to saying needs. And this is more on the developmental side, and very intentionally focusing on what it means to be in adolescence. And really this extends even to transition age youth. And if you're familiar with the publication last year from the National Academy of Sciences, Engineering, and Medicine, NASEM, they have The Promise of Adolescence. And if you have not seen that, I encourage you to see that. We'll have it at the end. The way they really pull out adolescence as a specialized period of life, in ways that sometimes it's easy to forget when you're working every day with teenagers. Because what are teenagers? Well, there's lots of adjectives to fill in there, and I'll let you do that quietly on your own or on mute. But there's a lot of ways to describe what teenagers are, both you know, a little bit tongue-in-cheek and both very seriously. But when we apply what are primarily adult developed diagnostic areas to adolescence, they just don't fit very cleanly, and they don't always last into adulthood because teenagers are very non-predictive in their presentations of what we would call symptoms. So rather than saying disorders, we say needs, and really we try to capture what those areas of needs are. And sometimes it stands out very clearly as a disorder. This is definitely depression. This is definitely ADHD, and that's fine. And certainly, as we conceptualize it, we don't discourage that at all. But we think that it captures more of the essence of the working with adolescents if we say multiply occurring and needs. So I don't know if that's going to catch on in the lexicon. We'll go from co-occurring disorders, which is COD, to multiply occurring needs, which is MON. So I encourage all of you to start using that next week in your meetings. So anything to add to that, Rick? Really, you were the one that started using multiply occurring before anybody else.
Yeah. So, when I think about how we deliver services in the kids' world, whether it's using, a wraparound approach or a community-based approach of some kind, we're constantly doing a strengths and needs assessment across life domains, across functional areas of the child's life, including, the family and the school and the peers. And there's different needs that arise that are not accounted for by the word substance use or a mental health disorder. And so we wanted to make sure that what we were doing was comprehensive enough and not missing major pieces and parts that we needed to address either in our assessment or in our treatment plan.
Yeah, thank you. Okay, Sarah, next one. So following this point of adaptation where we started to evolve our conceptualization, we started the Adolescent Intersection series, which was kind of 2.0. It wasn't 1 anything. It was the 2.0 movement here. So we started to really intentionally consider mental health, substance use, and trauma. And then we did this in the context of. So we kept substance use as a constant, and this is going to sound goofy, but we kept trauma as a constant, and the considerations of complex trauma, developmental trauma, and then intervening individual traumatic experiences. But then we considered that in the context of different mental health needs and disorders. And we covered the topics of anxiety, depression, ADHD, and externalizing disorders. And there's an interesting differentiation that we talked about between ADHD and externalizing disorders. And at this point, then, we also added the guy in the picture here. This is Dr. Christopher Balanci, if you're familiar with him. I think he's on an advisory panel for SAMHSA, and he's affiliated with some school out east. I forget what it is. Some little known school. What is it?
You mean Harvard?
Harvard.
Or Tufts.
Yeah.
He was at Tufts for a while, and then yeah. And by the way, this looks nothing like him, but this must be a younger picture of him.
Well, what else would you use?
That's true.
So yeah, he's if you've ever had the opportunity to hear Dr. Balanci speak, he has the rare ability to be as intelligent as he is, but he can translate it so that everybody can understand it and helps them all feel like they're smart too. My very first experience working with Dr. Balanci as he joined us on these discussions, he sent some slides to be added and some direction that he would like, and so I got that done and I sent it back to him, and he's like, "Hey, this is great. This is exactly what I wanted. Thank you very much. Just one thing, you spelled Harvard wrong." So, that was my first, but he was very nice about it. So, all right, next slide, please. Then we came down to really our last three, and the last one of those is the one that we have today. So earlier, was that this year, the end of last year? I think it was the end of last year. It was it was before we got completely locked down, I think. We talked about crossover skill sets, and this is another one like the discussion we had about workforce development with the crossover skill sets. I was very excited about, because we really got an opportunity to talk about how to encourage and expand the folks who are providing the clinical services to youth and families with these multiple layers of need. How intimidating it can be when you're thinking about providing services to kids who are that risky and that complex in family systems. And the good news in that is that most clinicians have a lot of the skills that they already need. It's just they maybe need to conceptualize them in slightly different ways, or use them in different ways, or be encouraged about some of the skills that they probably already have in place. And so we got to start on that, and then we're going to talk about that one in just a little bit more detail. And then really just at the beginning of this month, it was in the first week of July, we talked about COVID-19 and its impact on treatment to youth with multiple areas of need in their families. So luckily that's over though, right? And then today is the wrap session. So again, I am going to encourage you to use the chat box as we go through these different topics. And if there is a topic that stands out, hey, I'd like some more on that. If hey, I think it's wrong, just do that one to Rick. And then I'm joking to everybody. Any kind of comment, any kind of expanded discussion that you would like at all, please add that, because like I said, it's a learning community, and your participation is what makes it so.
By the way, I just want to add, Mike, that generally Mike is quite funny. Hopefully you'll experience that sometime today.
Thank you. I appreciate it.
Saying I'm joking, but I'm not laughing, so.
All right, fine. I'll try to bump it up a notch. Okay, so we're going to jump into now the specific topics that we talked about, starting from the early ones and then moving on. So next slide, Sarah, please. So our first topic, we started talking about prevalence, screening, and assessment. Really promoting the recognition that youth with multiply occurring needs, and at that point, really, we said co-occurring disorders, but youth with multiply occurring needs should be expected at any point of entry for clinical services, and that screenings should be in place at all, not just at all entry points, but at periodic points throughout the course of treatment. And that was one of the repeated messages that we had, that screening doesn't just occur during the assessment process. Screening is ongoing. And that's true for mental health, substance use, for trauma, for safety needs. It's easy to forget that we do screening outside of assessment. So that was one of the messages with this. Most youth with mental health or substance use needs do not receive treatment at all, and that's across the board. So most kids, when I say kids, I'm talking about, youth 12 to 18, 12 to 20, in that range. Most kids don't receive treatment when they need it, period. When youth need very specialized, intentionally integrated, focused treatment, like Rick mentioned in the beginning, the importance of a single message, a single treatment plan, the benefit of a single provider. That's not very available. We are talking about it. We're increasing the recognition of the benefits of it are certainly increasing, but it's still just not wildly or widely available. So most people with co-occurring needs don't receive integrated care if they get treatment at all. So, and that figure was from, who did that? I think that was the 2000, 2001 congressional co-occurring fact-finding thing. Fact-finding thing, by the way, is an official designation. So that was for all folks, not just for youth. But I think, even though I'm fond of saying we shouldn't apply adult measures to youth, I think that we can apply that one to youth, if most people in general aren't, and youth aren't doing it. So we promoted 3 specific prevalence measures that are available that we use quite a bit in terms of recognizing prevalence and really pointing out the areas of overlapping integrated needs that are there. The one that I use the most often is the Monitoring the Future study, and the link is there. And it asks such useful questions. It's not to youth. Have you ever used? But they also ask, what's your opinion of, how dangerous do you think it is? How available do you think it is in terms of drugs and alcohol? So really, really good, not just current prevalence stuff, but when you take a look at how dangerous do you think this drug is? How easy do you think this drug is to get? It also becomes somewhat predictive as well. And like I said, that one comes out every year. And so it's really nice to have the year-to-year comparison of that. The next 2 come out every other year. The Youth Risk Behavior Surveillance, that one's through the CDC. And, you know, with the CDC, it's more health focused. So it takes a look at a broader view of health and some of the risky behaviors that teenagers engage in. And it's very useful in that way. So it's very complementary to Monitoring the Future. And then there's the National Survey on Drug Use and Health, the NSDUH. If you've been doing this for a long time, you might recognize that one as the Householder Survey. It is, of the 3, it's the only one that is conducted in the homes. And so there's a slightly different prevalence measure or a prevalence outcome on that. And so it is really nice to compare to what you see with Monitoring the Future and the YRBS. So, and the links to those sites are there. You know, if you're doing a presentation, if you are doing some educational things, and you would like to have the most current prevalence information, all 3 of those sites are excellent. Rick, anything to add to the prevalence and screening discussion?
No, Mike, not on this one.
Okay, thanks. Next slide, Sarah, please. Okay, so evidence-based and promising practices was our next discussion. In this one, we really emphasized that you are already serving kids with co-occurring needs. So that was the message really coming out of that first one. This one building on that, emphasizing, well, the youth are already there, so how are you serving them? So we talked about integrated treatment is very doable. So, and this was kind of related to ones that were coming up later. And the necessary clinical skills are most likely already in place. I think we talked about how, you know, we see quite often when we work with programs, either agencies or individual programs within agencies, and then certainly with individual providers that are being called on to start to provide integrated services at some level, the level of anxiety that can be associated with that. You know, you hear things like, well, I'm trained in mental health, or I'm trained in substance use. I don't know the other side of this. You know, and as we're going to talk about coming up with crossover clinical sets and the workforce development kind of stuff, those skills are already there. Maybe not as deep level, you know, as you would drill down into with if you are a mental health specialist or a substance use specialist. But most of those skills are already there, and certainly the ability to screen for and then match treatment is already there. It is a matter of helping clinicians and helping programs recognize that those skills are there, and giving them the support in ways of implementing those skills. And so part of that support then is matching really with a good evidence-based or a promising practice. And we talked about quite a few of those. And quite a bit of what we talked about was built on the recommendation from NIDA's Principles of Adolescent Substance Use Disorder Treatment. So, you know, this one was specific to substance use disorder treatment, but it was it was very inclusive of co-occurring providership. So, and then there's a link to that if you're not familiar with that. We had some excellent guests that presented some information about some very specific topics. Dr. Little talked about MDFT, and Bernie, and I'm not going to try to pronounce her last name. Rick, can you pronounce it?
I think it's Centillo.
Centillo, thank you. But Bernie talked about MST and the long tradition of MST services and all the research associated with that. So, and we also talked about the ICT program, which is one of the very few that's out there that's very specific to providing integrated services to youth and to their families. Any comments or questions, Rick, from you, or very importantly, from our participants in the learning community?
Well, the only thing I will say here is that, when we talk about EBPs and promising practices for integrated work, you have to go deeper into the research to find those kinds of things. And what we're finding a lot of now are programs that were geared to one specific population, and they add on another component to their treatment. And then the research is usually based on the original model. So we don't know, if these programs that do these adaptations have specific evidence-based status for each of the adaptations. So, but we did include them here because I think it's really important that, like, programs like multidimensional family therapy, Howard Little's program, does a really nice job. It's mainly a substance abuse treatment program, but they've done a nice job over time to integrate mental health components into their model. And the same thing with MST. They've done a nice job, along with FFT, in integrating some substance abuse components into their models for kids with externalizing disorders involved in the juvenile justice system.
Yeah, thank you. And really, those adaptations were based on that recognition that we have been promoting. And I'm not going to take credit that we got them to do that, but that we've been promoting that. If youth have a certain level of or a certain type of need, it really predicts the likelihood that it's going to be on the other side. So the kids they were serving in MDFT, or the families they were serving in MDFT and MST, they had these complex levels of need. They were already there, and so the recognition of that they were serving these was one of the added components.
Yeah, and the only last thing I would say is that this is certainly not an inclusive list. I mean, there are other, and when we did our training, there were many other programs that went in this list, like 7 Challenges, the FIT program out of Washington State, and those things. But there are some programs that are more co-occurring than not. So they are out there if you're looking for them.
Yes, thank you. Yeah, and I'm glad you mentioned 7 Challenges, because that's one that it's pretty widely adopted. So, and I mean, we didn't have a guest speaker actually from so, but we did talk about it. So, and just a reminder, you have to click on the chat box and then type something and then hit enter, and your chat will be included. So, Sarah, the next slide, please. Okay. Next, we felt pretty compelled to do a discussion about opioids in particular, and not because opioids were a very popular drug of choice for the youth that we talk about on a regular basis. Actually, just the opposite. Opioids have been decreasing in popularity for the youth that we're talking about for quite a while. And as the opioid epidemic increased, the popularity of opioid use among adolescents has, in a matched fashion, decreased. So we didn't talk about it in terms of recognizing and providing treatment directly to youth who are using opioids. And we touched on that certainly. But the really important component is youth, kids, really from all ages, families are so starkly impacted by opioid use because it is commonly either the parents, the caregivers, the grandparents that were most strongly impacted by the direct opioid use, but then the indirect use had its enormous impact on the families that we're talking about, and the kids and the youth. So we dedicated a discussion topic to that. So, and as we presented it, you know, the youth aren't really using opioids very much. The youth, they're not using the weed, they're not using opioids that much. But those that do are at such a high risk. So as we framed that, then we talked about low incidence for the youth using, but really, really high risk. So the larger repercussions really are for the children, the youth, and the families that are impacted by the use of the parents, the caregivers. We talked about, and I imagine, you know, everybody listening has heard about how some of the child protective services and many of the foster services have just been overwhelmed by kids coming into these levels of care because of parental caregiver opioid use. So, and just recently, and obviously we didn't talk about this in 2014 or 15, whenever we talked about this, but just a month or two ago, the AMA released a brief reminding caregivers that the opioid epidemic has not gone away in the midst of our current pandemic, and it is quite possibly increasing. So we had, you know, gone on a steep curve from 2000, just kind of a skyrocketed curve upwards in terms of opioid use, abuse, misuse, however you want to frame that, and all of the consequences associated with that. And it leveled off and then it started to decrease. But now in the midst of the pandemic, we are seeing increased consequences associated with continued opioid use. And a lot of it really does seem to be with the, I'm going to say illicit, because none of it, it's almost all illicit, but you know, the illicit fentanyl and then the different analogs of fentanyl. So the overdose problems are not just with people who are using heroin or the opioids directly. It's every other class of drugs, and possibly influenced by the pandemic and the decreased availability of all the other drugs. A lot of drugs are being enhanced, so to speak, with fentanyl. Cocaine is, methamphetamine is, and so people are being impacted by opiates without even meaning to use opiates. So it feels like there should be something more I should mention about family impact with the opioid epidemic. Rick, anything to add there, or important?
Yeah, sure. You know, I'm really glad you brought up, you know, the analogs in fentanyl, because you know, it really, because of the closing of borders, different, you know, international borders and things like that, different drugs are harder to find. And what we're seeing now, I think, just anecdotally, is increased use of, you know, cutting fentanyl into other drugs rather than, you know, the availability of heroin and things like that. You know, in terms of family response, I mean, I think this really begs the question, or begs the response of, as a community, to have a full youth and family response in terms of whether it's wraparound or when we think about system of care and, you know, kids with multiple needs. You know, we don't open family cases usually in the kids world, but it doesn't mean that you know, that there couldn't be specialized needs at the caretaker level. And I think wraparound is pretty nicely matched to addressing all the needs that you might encounter, you know, from youth to caretakers. So Just keep that in mind, and these families need additional supports. And as Mike said, we have to think way beyond biological family at this point. You often need to think about finding the family. Is it grandma? Is it the aunt? Is it the neighbor? Is it, kinship somehow? Foster system ultimately might have to be the answer. But who else could help raise these kids while mom or dad are getting treatment?
Yeah, hopefully.
Yeah, hopefully.
Okay. Thank you. Okay, and I will respond to the chat box. Okay, I have. Next slide, Sarah, please. All right. I have a box pulled up in front of this. Oh, suicide prevention. So something else that has been unfortunately increasing here recently, and it has been noted in the midst of the pandemic, but certainly the rise in occurrence, prevalence, however you want to frame that, started well before the pandemic, but there has been increased concerns within the pandemic. In 2018, the CDC found that suicide was the second leading cause of death behind accidents for, look at all these age groups, 10 to 14, 15 to 19, 20 to 24. Second leading cause of death. The only good news in that at all is that in the two top age ranges there is it replaced homicide as the second leading cause of death. But suicide, it kind of ebbs and flows a little bit, but concernedly here recently it has been flowing. It's been increasing. I try to think which is ebbing and which is flowing, but it has been increasing. The recognition of the signs and the symptoms, and when you're working with teenagers, it can be very daunting when you're working with teenagers, when you are clinically responsible for screening for and asking questions around suicidal ideation, self-harm, suicide attempts, suicide thoughts. What has been really found most often, and that we talked about, and Rick has talked about this for a long time, that recognizing that with teenagers, suicidal ideation and attempts are most strongly associated with, the strongest predictor is a recent relationship problem. Either a romantic relationship has ended, or there has been a big relationship conflict with friends. And this is at the peer level rather than at the family level. I mean, the family level is involved as well, but this is peer level. Recent relationship problem was the most commonly identified antecedent, and something that we should always be aware of, screen for. And again, with the screening discussion, screening does not end at assessment. Screening goes on all the time. So, Rick?
Yeah. Thanks, Mike, for that. The other thing that presents is additional risk factors, and that's why we decided to have something on, youth with co-occurring disorders and suicide prevalence, is that substance use increases suicide attempt. And so when you combine substance use and depression in particular, those two predict increased suicide attempts. And then when you add on to that, with boys in particular, impulsive aggressive behavior and or conduct disorder, these are all things that lead to increased suicide attempts. And these are things that are quite common in kids with co-occurring disorders, right? Depression, conduct, impulsive aggression. So if you're going to be working with this population, we think we strongly recommend that you get well-versed in risk and protective factors for suicide, and be able to, ask the questions, maybe even be able to jump into a lethality assessment if you have to. Kids aren't as obvious prior to an attempt. It's very impulsive usually. There's social media that could be involved. And because it's not as obvious, we have to be better at identifying the precipitating factors. So that's why we wanted to have a learning community on that. And so I think that one for sure is on YouTube because we did that more recently.
Yeah, thank you.
Mm-hmm.
And building on what you said, you know, in terms of the overlapping and the combining risk factors with the increased impulsivity and the really the overt aggressive kind of stuff when you mix drugs and alcohol in that, and with the increased impulsivity, that really increases the chances. So, and I think the comfort level with the risk and protective factors that you talked about, Rick, is very important. And again, it's one of those things that it can be difficult sometimes to get people to work with adolescents because there is so much to balance and so much to understand, and part of this is the high risk factor with adolescents. So, okay. Next slide, please, Sarah. All right, so then next we did the workforce development one, which really it built on a lot of the different things that we had talked about up to this point in terms of the skills that we were promoting and the approaches that we were promoting, and things that maybe sounded a little bit anxiety provoking, but that were probably already in place. And so this one was, if we're promoting these clinical skills and these clinical approaches, who are we going to get to do that? So workforce development was our next topic. We talked about and covered recruitment, retention, and really this sounds like working with clients, doesn't it? I mean, you gotta find them to get them in, and then once you get them in, you have to keep them, because without that level of engagement, you can't do anything. So recruitment, retention, training and development, and that's a really big one, and that's one that Rick has talked about. I keep saying this, Rick has talked about it for a long time. I keep saying that because Rick is old, he's been doing it forever. But he has also been doing it forever at a really high level, and as I have, you know, when I first started out, I was 3 years old and Rick was already 50, and he was talking about training and development after you, I'm kidding, I'm kidding. Rick is my boss, by the way. The coaching and the consultation, the training, the development, all of that stuff that occurs after the person is done with school, after they've taken their licensure exam, or as they're preparing for that. All of that comes after that because there is so much involved in the specialization once you get out of school, and you can't expect that to all be done in school. And so then it falls to the programs and the supervisors and really the clinical community to help build up those skills and the support involved with that. And then once you get a program in place that has these skills, how do you sustain that program? How do you have a champion for that program in each of the communities, whether it's in a community mental health board or Adams board or you know, agency by agency kind of thing. So before I move on to the next slide, Rick, do you want to defend yourself or add anything?
Well, no, yeah, I just want to correct some of your language. Mike said that he's my boss, and I just want to, it was his boss, was I think the right way to put that. So yeah, workforce development is such a critical thing, and we often talk about don't get stuck, you know, or don't stop your development or implementation because you think the workforce might not be there. I would just assume that those integrated, specialized professionals are not there, and you've got to go create them, and you start where you are. And if you're a mental health agency, you want to bring in substance abuse expertise. We believe that the supervisor is such a critical role, so that, you know, you want the supervisor to have dual skill sets and train up the team, you know, to learn these things together. But it's not impossible. It's entirely doable. Mike and I have been doing it for a number of years. You might need some extra outside training or consultation, those kinds of things. But, you know, the take-home message here is that you can do it.
Yeah, it very much is. That it is really doable. And really, that's the right side of that slide. So thank you very much. Okay. Comments? Anybody? Sarah, next slide, please. Okay, so at this point, then we moved on into it as we introduced kind of the next phase, the 2.0. So the message really remained the same, but the conceptualization was a little bit more intentional in its individual components. So this is where really we pulled trauma out as a separate identifiable and very, very informative component. And really it captures the whole, not the whole, but it captures a significant portion of the developmental piece that's vital when you're working with adolescents. So as we initially conceptualize things, and as the way most of the conceptualizations are still done, you think about co-occurring disorders, and that there's a mental health disorder that can be identified independently, and that there is a substance use disorder that can be identified independently, and there's your co-occurring disorder. So as we moved into this phase of consideration, we stopped using as much. It's tough to remove completely, but when we're talking about adolescents, we talk about needs as opposed to disorders. And yeah, you know, kind of gray area there in between. But started to conceptualize and started to think about the areas of need that the adolescents that we're serving are living with. And that is there are mental health needs, there are substance use needs, and then for a significant portion of the youth with those co-occurring areas of need, there is some sort of developmental unmet need. You know, and whether we want to call that developmental trauma, or unmet Ericksonian crises, or, you know, unmet developmental milestones, however you want to frame that, the developmental lack, the developmental insufficiencies during very, very pertinent periods of development have such a profound impact on the other areas and look like the other areas that we really want to consider that separately and very intentionally. And so this is how then we started to move into the next area of conceptualization. Sarah, you can move on to the next slide. Rick, I don't have anything to add to that yet or not. The next one kind of builds on it.
Well, I was just going to add a comment from the chat box, Mike.
Oh, good heavens, I missed it.
Yeah. Andreas adds that was considering the multiplying effects at this time with the pandemic and increased awareness of social and racial inequities in the country. So yet, even more factors to consider when you're working on your assessment and deciding how you want to help the family. Yeah, thank you, Andreas.
Yeah, absolutely. And so the pandemic is likely contributing to areas on the developmental side where there are increasing levels of unmet need, right? Really, and for all age groups. And, you know, if you take the Ericksonian approach for, you know, my age group as well, you know, we're getting towards the end of it, but, you know, the development never stops. You know, in terms of the social and racial inequities, I'm hopeful. I'm a humanist, but I'm not necessarily an optimistic humanist. I am hopeful that the increased recognition here then will start to have a positive impact on reducing the impact of some of that. It's not going to happen quickly, obviously, but I'm hopeful that the increased recognition will have a positive effect on that. So, but I'm really glad you brought that up.
Yeah, I'm sorry. Oh, okay. So yeah, and I think in addition, you know, we've seen over the years that, you know, access to mental health and or substance abuse services has been limited. for certain, populations, and for co-occurring even more so. So those are very real issues that we need to address. And as Mike said, around the pandemic, when you isolate folks, you're going to be stunting development. And we think we look at this from an educational standpoint. Kids falling behind and things like that. So how is that going to affect things, right? So great points. I'll let you get back, Mike. Sorry.
Oh, no, we could probably just go on and wrap up talking about that, right? What is going to be the impact on the youth that we're serving as we move into this next phase, and the educational decisions and the anxieties, but we will move on through the slides. If you guys want to redirect it, though, and thank you, Andres, I'm probably mispronouncing your name, I apologize. But thank you for contributing. So each discussion from this point, then, we considered these multiple areas of overlapping areas of need. And then also it's important to talk about the areas of resiliency and the strength factors involved in the different areas in terms of the way we conceptualize them. So we talked about substance use, developmental trauma, and then we tackled very specific mental health topics. And we're going to get into those next. So if we can go to the next slide, Sarah, please. So we started talking about, in terms of now our TRI consideration. We tackled adolescent depression first. We went through the DSM and talked about some of the challenges in using the DSM to understand different types, different conceptualizations, different expressions of depressive disorders or needs as they appear in adolescence. And they so often don't look the way they do in adults, or the way that, we are taught to expect them. And it starts out in the DSM-5 now with DMDD, or depressive mood dysregulation disorder, which was designed very specifically to address those needs for adolescents. In my experience, it has been identified or utilized less than I thought it would for the youth that we serve, and maybe that's around some of the different criteria, or I'm not sure. But we did have a discussion on that. We talked about major depressive disorder, persistent depressive disorder, dysthymia. We didn't really talk about, in terms of adolescent application of the premenstrual dysphoric disorder. But we did talk quite a bit about substance-induced depressive disorder, as that relates to the intentionally integrated piece with drugs and alcohol being a part of that. For DMDD specifically, we pulled that one out because that one is very, very adolescent specific, with temper outbursts, inconsistent with developmental level, mood between outbursts is consistently irritable. And the way that DMDD presents, and then we really talked about the overlap if this youth has experienced trauma during their development, whether that was abuse, neglect, which can be really chronic, or if it was individual significant traumatic experiences, as if there's insignificant traumatic experiences. But and talking about the difficulty in differentiating those symptoms. And it really does matter too. It's not just, we've got the flavor of this is kind of a depressive-ish kind of thing. It really does matter if it is coming from really more of a neurological complex trauma background, or if this is, and you could say neurological also, but from more of a depressive standpoint. And so the treatment match, and especially if you are working in conjunction with medical and psychiatric services, and the match on that direction, then it really is significant in helping to understand and expand the understanding of the etiological basis for the behavioral presentations that you're seeing. So that's all I have to yap about on this one. Anything to add, Rick?
No, I don't have anything extra on this one.
Okay. You were thinking about your shopping list, weren't you?
Well, it is Friday afternoon.
Yeah, I know. That's and really, I said that for everybody out there listening. Rick and I attend a lot of these webinar presentations, and it's tough not to be doing your email and jotting down, oh, I need to pick this up and pick this up. So, and that's just my way of reminding you that there is a chat box that you can put some of your grocery items in there, and we can talk about them. So, Sarah, next slide, please. So the next one we added.
Speaking of anxiety, Mike, you know, my anxiety around grocery shopping now is how do I combine all my trips? Because if I'm going to mask and glove and goggle up, I want to make sure that I can just do it in one set of trips.
That's right. Yeah, and not just in one set of trips, but are people going to be too upset if I spray everything down with Lysol before I take it off the shelf and put it in the cart?
Well, there you go.
Yeah.
So now that you know about our anxiety, go ahead.
So, in moving into anxiety, then, that was our next topic to add to. So, substance use, developmental trauma, and then talking very specifically about anxiety. And it is such a component of being a teenager to have, I don't know if symptoms is the right word, or expressions or experiences of anxiety. And I think it was at this point we talked about if you apply direct DSM, the study was done with DSM-4. If you apply the criteria as listed in the DSM, like 50% of that's an exaggeration. I forget what the actual percentage was. It was a very high percentage of teenagers have diagnosable levels of expressed symptoms of anxiety. When they go back in and they look and they say, is it actually causing a problem in that teenager's life? The numbers drop down slightly below where depression is. But anxiety is just a normal part of the teenage experience. And so how much of it is normal, how much of it is problematic, and understanding that diagnostically, especially as it overlaps, if there's substance use going on, if there is a history of complex trauma, if there has been recent trauma, you know, all of that makes anxiety very difficult to understand from a diagnostic or a conceptualizing way in teenagers. And so there's the different areas. I'm not going to go through those. But then we also talked about here and pulling out from the DSM in terms of your understanding, or my understanding anyway, that substance-induced or medicine-induced disorders is a big component when we come to thinking about the overlap of substance use and the rest of the mental health disorders. Anxiety is probably most strongly impacted by substance-induced mental health disorders. And so we didn't go through and talk about every single category of substance separately, but certainly we did talk about, you know, the ADHD meds, are they being used appropriately, are they being abused? The prevalence now of energy drinks and the easy availability of amphetamines, and methamphetamine use is on the rise, and nicotine is a significant contributor to that, and with vaping has actually started to go down just a little bit, but teenagers are vaping a lot, and you can choose your level of nicotine, and that can really add to the appearance of or the exacerbation of existing endogenous, you know, anxiety. So that was our discussion on anxiety as it overlaps.
Got nothing more. That was good. Thanks.
Thanks, Rick. Okay. Sarah, next slide, please. How are we doing here on time? I should probably talk faster, huh? All right.
Yeah.
All right,
And by the way, I'm going to start judging you after each slide. I'm going to kind of, you know.
All right. So, yeah. Okay. This was
that
good.
Was okay,
All right.
Yeah. All right.
Okay. So next we talked about externalizing disorders. And in externalizing disorders, we had a little subcategory of talking about ADHD, because ADHD is so often conceptualized as an externalizing disorder, but as it's framed in the DSM, it is no longer, you know, but it really looks like it, right? And then how do you differentiate and understand complex or developmental trauma from externalizing disorders? Because what do kids who have lived with a lot of trauma, especially early in their development, look like? You know, they look like externalizing disorders kind of stuff. Every teenager in the world that I have ever worked with clinically has, at some point in their life, that's an exaggeration, but not a gross one. At some point in their life, they've been diagnosed with ODD. So, and for those of you who are working with teenagers, you know, a significant portion of them come to you with either a current or historic diagnosis of ODD, and often it overlaps with ADHD. And are those accurate? And really that has been the message in terms of this 2.0 version is that really accurate? Is this really on the mental health side? Could this be complex trauma? Could it all then be exacerbated by substance use and then also a strong consideration of family systems? So in my effort to speed up, that's all I'm going to say about externalizing disorders. Thumbs up, thumbs down.
Well, no, I'm just going to tie back in here what we had talked about earlier, which is the risk factors for suicide.
Yeah.
The one thing when I was updating my research on that really surprised me was that conduct disorder in particular, right behind depression. So when you, again, these externalizing disorder kids that have impulsive aggressive, traits have higher risk factors for suicide. So when you put these things together, I often say, Mike and I often talk about, we are tasked with being the risk managers for the community when we start helping kids with co-occurring, and that these kids often have higher risk profiles. So a lot of what we do is we have to be good at assessing, we have to be good at safety planning, and as such, because the risk does increase.
Yeah, it does. And I'm glad you mentioned that. Thank you for slowing me down, even though I know that wasn't your intention. But with conduct disorder being so high on that risk factor, especially as it comes to suicide risk, I mean, that is really telling. That so often, even those of us who work with teenagers on a regular basis, I think tend to frame conduct disorder and maybe a little bit the oppositional defiant disorder is some kind of internal intentional mechanism of that teenager, that this is a conscious decision to be a pain in the butt. And teenagers do make conscious decisions to be a pain in the butt, and that's perfectly normal, but at the level we're talking about it is different. And so what is really driving that? And so often we see the linkage there with the complex trauma and really the family system disrupting. So Sarah, the next slide, please. I think it was in our discussion on externalizing disorders. It might have been the one on ADHD, and I can't remember which. Rick, hopefully you do. It was one of those two, and I know both of these are recorded. We had Dr. Balanci in that discussion, and he did such a wonderful job of talking about psychiatric medication, the considerations around adolescents in general, but then especially adolescents with developmental trauma backgrounds and co-occurring and multiply occurring needs. So I really encourage you to go back and look for that one, the one with Dr. Balanci talking about medications. This quote is not from Dr. Balanci. This is from Dr. Vanderkolk. And I imagine all of you who work with teenagers are familiar with Dr. Vanderkolk and his work on developmental trauma over the years. 500,000 children in the United States currently take antipsychotic drugs. Children from low-income families are 4 times as likely as privately insured children to receive antipsychotic medicines. These medications often are used to make abused and neglected children more tractable. I mean, we could end with that, quite honestly. We're not going to. I'm going to keep talking. But and that was really a core message from Dr. Balanci as well. These medications make children more manageable and less aggressive, but they also interfere with just development in general. So, and that was the message. So, next slide, please, Sarah. Then we tackled ADHD and neurodevelopmental disorders, and this is just about the last one. And in terms of our adolescent intersection series, this was the last one. So, coming on the heels of externalizing disorders and having some similarities and overlap, not necessarily in etiology or the way that we should approach treatment, but in the way that it is often considered. We talked about intellectual disabilities, communication disorders. We talked about autism spectrum, and then focused most heavily on ADHD for obvious reasons, because so many of the youth that we work with come with that diagnosis, whether it's accurate or not, and some of the considerations in that accuracy. In the very first chapter, in the developmental disorders chapter, the DSM notes that the neurodevelopmental disorders are a group of conditions with onset in the developmental period. And I wrote that down because it just amused me that the DSM-5 is apparently Freudian, thinking that the developmental period ends at the age of 12. I'm more Ericksonian, so it spans the lifespan. But certainly, I understand what their intent in that is that it's early in development that we see these neurodevelopmental disorders. So, did I just see a chat pop up, Rick? You're muted, by the way.
Sorry. Given your last quote, it is vital what we have that we have viable medical histories. Given that many of the youth are from low-income families, access to basic primary health care is limited. And that's from Andreas. Yes. So, you know, we haven't talked a lot about health, and we haven't talked about primary care a lot. But there also is that intersection of, you know, making sure that there's adequate consultation to primary care around specialized needs of these kids.
Yes. Yeah, and really, I think that is the next level of integration, isn't it? That's the next one up, where we can have that that crossover consultation, and hopefully just you know, a single point of entry for youth and families, just to increase the likelihood of that engagement.
You know, and I think it also points out that we really have to focus on the assessment piece of what we do. You know, are we saying that these kids actually have symptoms of psychoses? Are we saying that we're just going to use, you know, drugs off label? Regardless how we do this, it's going to take additional training and consultation around those things. By the way, Mike, I just want to point out, I'm counting how many times you say Ericksonian today. So I think that was 3 or 4.
Well, and how often have any of you heard anybody use that term? Really more than once a month. So I'm throwing it in intentionally. All right, Sarah, if we can go to the next slide, please. I encourage all of you to look at and access, if you're not familiar with the National Child Traumatic Stress Network, I encourage you to become very familiar with that resource. But specifically to a brief that they presented in 2016, I think it was titled, "Is it Trauma or is it ADHD?" And it really specifically talks about and helps in some decision-making in that differential understanding. And as Rick said, that assessment piece that we do is so important, but that assessment piece is not that 90 minutes that we're given to do the initial assessment, because you have to gather so much information and it's so, you know, it's so paperwork oriented. That assessment is ongoing, and we need to be open in our screening and assessment willingness with the youth that we serve, with these complex levels of need and these complex areas of need, and the families as well. That the assessment period continues to go on, because you're not going to understand in the first 90 minutes these very complex areas. So, and this is a good example of that, trying to differentiate trauma and ADHD. So I'm not going to go through this because I've taken too much time in the other ones. But I do really encourage you, if you're working with youth, take a look at this brief, take a look at the NCTSN website. If you're not familiar with it, it has so many good resources. And again, it has so many good resources across the whole lifespan. So, Sarah, the next slide.
I'm reminded, Mike, that, you know, I love your new slide. I'm reminded that, you know, part of our work is to be good diagnostic detectives.
Yeah.
You know, the whole idea of differential diagnosis, if we really take a look at this with complexity, it is really kind of hard to diagnose youth. And it shouldn't be easy, and we should take some time with it.
Yes. Yeah, and I mean, that really is the message, is take your time with it. Your individual sessions are not billed as assessment sessions, but they are assessment sessions. And be willing to update your initial diagnosis. And I know that can be a pain in the butt to do. But But one of the biggest gifts that we can give youth and families with these complex areas of need is an increased understanding of what is really going on. Not a laundry list of diagnoses that frequently, and now here's the cynic in me, that frequently they've angered a clinician, they've ticked somebody off, and so they get ODD and conduct disorder and ADHD. But what's really going on, and that understanding to help them truly match the appropriate level of treatment and the appropriate levels of care and the right kind of care is one of the biggest gifts that we can give them. Keep them engaged, help their understanding. So the last two that we did then, crossover clinical skill sets, talking about differentiating the different areas of skills that clinicians have and can bring to bear, and how we can bring in, as Rick was talking about before, we can bring in somebody who's more experienced in this area, more experienced in this area, and working as a team whenever possible, and then also increasing skill sets in our individual clinicians. And then the last one we talked about was the COVID-19 impact on treatment. And we did quite a bit of discussion about the delivery of telehealth and, hence look directly into your phone and tell me how you're feeling. Both of those I know for sure on the YouTube channel and are recorded. I was really happy with both of those. I don't know if that means anything to any of you listening, but I think that in terms of participant input and the information that they were able to share, I was really happy with both of those. So, Rick?
And it's all about your happiness, Mike.
Well, that's really what it comes down to.
So, what we've tried to do, is this one of the last slides?
Yeah, we're really close.
All right, I'll let you finish. I was gonna do some summary stuff.
Oh, okay. Let's go to the next slide then, please. I think that this is probably the last one because we have dropped the microphone. Now this is my biased argument. I will say that this is from my perspective. Rick did not make this biased argument. He can either lend support or tell me that I'm going back to school. Biased, it is very arguable because whatever population you work with and serve obviously is going to be the one that you focus on. It is my assertion that providing services to youth and families with multiple areas of need is the most important clinical work that you can do, because working with teenagers during that developmental period offers the greatest chance, not just for insight from the teenager, but for meaningful change moving forward, not just for the individual, but in a meaningful generational way. So you work with the youth, you work with the family. If you can bring about even small amounts of change within that family, if you can bring about small amounts of change for an adolescent, for a teenager during that period of life, because they have already lived through any of the developmental trauma that is in their history, if we can help steer them away from future traumas, or at least the intensity of future traumas, and help them move in a way that they understand what's going on and can make decisions around that, that we have the best chance working very specifically with this group of folks. So that's my argument for what we do. And then thinking about where we go from here.
Yeah, thanks, Mike. I mean, I think that's a great way to end. I love the way that you put that. I think that, what we've been trying to offer is lessons learned from really, Mike and I together have been implementing this integrated co-occurring treatment program for many years, and a lot. I mean, what's interesting is that if you dive into a field that nobody else is really working on, you get to experiment and try and relearn and learn. And so all we're trying to do is share with you what we've learned over the last actually 20 years now. And hopefully, so you don't have to go over and reinvent the wheel areas. The other thing that I want to mention is, as Mike said at the very beginning, this is our final learning community for co-occurring disorders. And but Mike and I, our contact information is on the last slide.
I think it's on the next one. Yeah.
Right. And we just want to make sure that, as you guys have ongoing questions, we're always available. So all you have to do is email us and we'll be happy to get back to you and try to answer whatever questions you have. But before you email us, we'd like to give you the final opportunity Do you have any questions or comments before we close out for today?
And I will mention quickly, it's written down there, but if you look back at this afterwards, and because of all of the great information that we had, I know that you're going to review this time and time and time again. But if you do come back to it because of any of the points in the slides and any of the connections in the slides, I tried to include all of the references we had over the last 6 years. And I know I didn't capture all of them, and Sarah, you don't need to go through them. Like the next 8 slides are all references in the areas that we have been talking about in terms of research and linkages and prevalence measures and things like that. So if you're doing any work in this area and you need to draw some information, looking at that reference section might be a helpful starting point.
Okay, let's see. I'm just looking at the chat and.
Well, Sarah added, before you go out shopping for the list that you made, please complete the brief survey. Yeah, and really, I think that that's it.
All right. Well, we want to thank you again, everyone, and be safe.
Yep.
And enjoy your weekends.
Yeah, absolutely. And thank you, everybody, for your time, not just this time, but for across the times.